Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm joined by Ali Abel, who is a fourth-year medical student at Albany Medical Center, and we are about to interview Daniel Hofer, a family physician, a board-certified practicing family physician, who is Chief Medical Officer for Outpatient Palliative Medicine at Sharp Healthcare in San Diego, California. Dr. Hofer, thank you so much for joining with us.
Very happy to be with you, Larry.
So I'm going to turn things over to Ali now.
Okay.
Hi, Dr. Hofer. I was wondering if we could start off. This interview with you giving us a little bit of background about yourself, like where you're from and what inspired you to become a family physician.
So, wow, that's a lot of questions. That could take an hour. However, to give you the short version, I have lived in Southern California for most of my life. I spent 4 years in Virginia at Eastern Virginia Medical School, then came back to UCLA to do my residency through Northridge Family Medicine. I came down to San Diego and have been working for Sharp Steele Medical Group and Sharp Healthcare, and I've been here now for 27 years. I have had many roles in healthcare, done virtually the majority of roles in post-acute care. So I've been a home health medical director, hospice medical director. I've worked in nursing homes, and now I'm working as the chief medical officer for outpatient palliative medicine for Sharp Healthcare. And I see patients every day in my office. Well, not under the current circumstances. We're doing a lot of telehealth, but every day in my office as a family physician.
You wear a lot of hats.
Well, I have worn a lot of hats. There were a couple now. I'm just the CMO for outpatient palliative medicine, and I'm a working family physician.
So can you tell me a little bit about Sharp Hospice Care and that organization?
Yeah, so Sharp Hospice Care was the foundation organization for which the community-based palliative medicine program transitions grew out of. Sharp Hospice Care has been up and running for over 20 years. My colleague who helped me create the program, I created the medical side of the program. She created the administrative side, which, by the way, is a sign of hospice care, is that you work as a team. And in this approach, we're able to create a community-based palliative medicine program. Now, Sharp Hospice, our hospice itself, we on any given day manage about 550 patients between the hospice and palliative care team. We do a lot of educating, a lot of teaching, a lot of personal in-home care for our patients.
Can you kind of describe the leadership team of this palliative care program? How do you manage everything?
Sure. Well, so palliative medicine is complicated. If you're talking specifically about the community-based palliative care program transitions, so this was created about 15 years ago, and the leadership team would be Susie Johnson is my colleague and co-creator. I'm the medical director. We have an administrative director, nursing administrative director. And then the team itself is built up of nurses, NPs, doctors, social workers, chaplains, and pharmacists. And so we meet as an IDT, which stands for interdisciplinary team, and we discuss every single patient on admission and for recertification to help make sure that the care we're providing is consistent with their goals of care, to be sure the family's reconciled in that care and doing everything we can to keep that patient in their preferred place of residence.
So, Dr. Hofer, if I can jump in, as you've explained to me in past conversations, your outpatient palliative care team has a relationship with the primary care physicians and the subspecialty physicians in your system. Could you talk about that a bit?
Yeah, absolutely. So I think, so let me tell you, Larry and Ellie, the answer is that, so you need to understand the program, because we're not your typical community-based palliative medicine program. So when my colleague and I conceptualized this program 15 years ago, we were working together on hospice, and we saw these patients come onto service that had literally been admitted to the hospital 10 or 15 times, let's say for a heart failure exacerbation. We would take them onto hospice, and we would manage them so proactively in their homes, they wouldn't have another exacerbation until they died, but they would live another 2 or 3 years. Just amazing how many times they had been hospitalized, and how well we could manage these patients without needing the hospital. And so when we created the program, we used professional in-home management skills that I'd learned from home health, that I'd learned from working in nursing homes, that I'd learned from hospice. We used something that is rarely taught anymore, but that's evidence-based professional prognostication, and you can ask me about that later. I can tell you right now that most people believe you cannot prognosticate effectively, and I am telling your listeners that that is not true, that they just need to learn some basic tools to become more effective prognosticators. We use professional care for the caregiver, and then we use professional support for the patient's family. And these are all evidence-based tools, so advanced care planning would be a part of that fourth pillar of the program. But one of the things we did in our program, I should say there's two things that are particularly important. Number one, at the time, back in 2005, there was very few community-based palliative medicine programs. 90% of palliative medicine at the time was being practiced in the hospital. Of the few programs that were available, they were piggybacking off of home health or waiting for the patient to be hospitalized. But why would you need to do that in a proactive management style? It's just it's a cultural concept, a construct concept in healthcare that's very hard for people to get past, that the hospital is not a necessary tool for the most aggressive patient management. But by using Medicare Advantage and shared risk contracting, we could anticipate when the patient would start to use the hospital as a tool for decompensation management. And so we engaged the patient before they went to the hospital. The significance of that for every primary care physician and specialist out there is that when you sit in your office and you see a patient and you know you've done everything you were supposed to for them, you know your consultants, your specialist, or the primary care physician you're working with has done everything they were supposed to, but you send that patient home and in your heart you know that patient's going to end up in the hospital before they make it back to see you, that's when you should have sent the patient over to our program. We can manage those patients without needing the hospital. And having said that, if you can't, you'll probably understand then why I'm a little bit frustrated by the concept of preventing readmission. We should be preventing primary admission. That's issue number one. Number two is no doctor who's taking care of a patient for a prolonged period of time. I know many of my patients now for 27, 28 years wants to give up their patients. So we are a co-management service. We offer evidence-based professional advice about proper management of the advanced elderly. Patients are expected when they refer to us by their physicians to go back to see their primary care physicians and their specialists until they cannot. And there are many patients that can't see the doctor, so we're just an extension of the physician, but there's many patients that can. And so one of the things that makes our program unique is that our patients don't need a Medicare Part A skilled need. They don't need to have been hospitalized, and we don't take over their care. We work with the referring providers to manage their patients in the patient's preferred place of residence.
And so how does that go across? I think there might be some tension or some suspicion that, especially when you were first starting off, how did you communicate that? How did you build that rapport and trust with the primary care docs and the subspecialists?
Well, I think if you work long enough as a primary care physician, you could see this need, but there was no service available to make that happen. And most of us have sat in our offices going, the time to get home health involved is after the event has occurred, and that's unfortunate. And I don't want to use the nursing home as a treatment tool. I want these patients to be able to stay at home. For me, it was fortunate because I worked with my colleagues and I could explain along the way what was going on. The harder part of the story, of course, was working with the specialists, because at the time, especially, many of them did not conceptualize not dying in the hospital as an appropriate standard of care. But I will tell you this, you don't need everybody to agree with what you're doing. You just need to get a few advocates for your model. You work with them, and then the ones in the middle will join in. And virtually every physician that initially wanted to shut our program down, I'm thinking of one specialty in particular, has joined in and said this is one of the better programs available to help them manage their patients. And they can refer as well, which they do.
So that's got to be pretty satisfying to have had that kind of response. So you're actively building teams, or networks, if you like, that are allowing for the best outcomes possible for your patients.
Absolutely. Well, once they understand what you're doing, and it's a constant educational process, because we get a lot of people into our program, new students, new physicians, or no longer students. They've left their residencies in medical school and they've come into practice, and they've learned the management styles that were in their environment or their region. And we say, well, you may have had a palliative program or not, but this is what we do and how we do it, and this is how we integrate that care. It helps for us, and because we have a significant amount of shared risk contracting. So you can do this with ACOs, you can do this with Medicare Advantage, you can do this with any type of a contracting that is shared risk. At least I should say that's the easiest way to do it. You can also do it with fee-for-service, but the economic modeling for hospitals to make that a benefit is a little bit trickier, but I will tell you that it can be done. And yes, it's very satisfying because you have to partner and you have to understand how not only your systems work, but the economics behind your systems work.
So help me understand the culture. I mean, culture drives organizations. And I know that you've been very thoughtful in terms of how you build the culture within your team and within the larger system. Could you speak to that also?
Sure. Well, the culture is a paradigm shift. And most of us, although this is changing, many of us older doctors, and I say that as I'm approaching 60, we were trained in the acute care model of disease. Once you're broken, we'll fix you. The new models that you're seeing in virtually everything is proactive management. But proactive management comes at a cost. So whereas medical groups and patients will benefit, hospitals may not benefit in the same way, especially if they're primarily a fee-for-service hospital. But the other part of the culture, so that's the economic piece, the other part of the culture is to understand that when you're creating a culture shift, that is a lot harder than introducing a new medication or a new procedure. We're used to integrating new procedures and medications in our thought processes, but integrating a new construct is remarkably different. And that was the initial problem back 15 years ago, although I think it's much easier now because many of these programs are popping up. But you have to work with your advocates that produce results, and then you can show those results to your colleagues, and then more people buy in, and then you can start a catalytic change in what you're doing. So I would tell the listeners that when we started the transitions program, we didn't do what many community-based programs did, which is to eat the whole elephant at once. We took one disease. We took congestive heart failure, and we became so good at proactively managing congestive heart failure that we decreased primary admissions for heart failure exacerbation. And that's primary, not readmission. we decreased those and have maintained that for 15 years by 90 to 94%. If those patients get admitted to the hospital, they're a third less likely to be readmitted. But we were so successful in managing patients by this proactive modeling that other subspecialties wanted us to build a program for them. But remember, there's 4 tools. You have to use professional in-home management, you have to use evidence-based prognostication, professional care for the caregiver, and advanced care planning. So you have to learn the disease to be able to provide the in-home management and the prognostic skills to talk about the different types of prognostication within that disease process. Once the specialists got used to understanding what we were doing, we regularly get referrals from neurology, for example, for dementia and neurodegenerative disorders. We routinely get referrals for COPD and heart failure now. And basically, we get referrals for every diagnosis there is. It's just that was how the initial culture change had to occur.
Got it. So tell us more about prognostication.
So, if you look at Socratic physicians, I have a slide that shows, and I'm not going to be able to quote it specifically, but the most important skill a physician can have, according to Hippocratic physicians and Socrates, was the professional skill of evidence-based medical prognostication. And what Nicholas Christakis showed us back in the 1980s, that we virtually stopped teaching about prognostication. So any comments you hear about prognostication for the last 40 years, for the most part, have just been grandfathered sentiment. And that's unfortunate. When we talk about prognostication, most people think about time prognostication, how long until the patient dies. And for example, the patient has 6 months on hospice, so they have to have 6 months or less to be hospice appropriate.
Right.
However, there's many other types of prognostication, and we use the 3 categories, which are event prognostication, probability prognostication, and time prognostication. Event prognostication would be similar to anticipatory guidance for children. What's the next event in the expected series of events as the child develops? Well, you can develop those same models as the disease declines. And so you can anticipate what the next event is. I'm not particularly worried whether the next event is going to happen tomorrow or 6 months from now. I just want to know what the next event is, because if I know what's coming next, I can talk to the patient, I can reconcile the family as to what we're going to do when that event occurs. And that to me is more important than time prognostication for death. So the other one is probability, which we use occasionally, but we don't use it enough. It's what's the likelihood that the event is going to happen. So if a patient goes into the hospital and they develop hospital-induced delirium, which, by the way, has a higher mortality rate than COVID-19 for the advanced elderly. It's a deadly disease that's been out there, a silent killer for decades, and nobody thinks about it or talks about it. But I can tell you how likely you are statistically to develop that problem when you're in the hospital, so you can be sure you want to go for that procedure, or be sure that you want to use the hospital as the tool for the next event. And wouldn't it be better? COPD is such an easy example. Nobody wants to go to the hospital when they have COPD, because that's where if they went in with just a minor exacerbation, they come out with a pneumonia or the flu or whatever was going around that season. And so by catching them early and treating them immediately when symptoms occur in their home, we can decrease hospitalizations and exacerbations.
So if I can apply that to the current crisis, if all across the country, frail elders were treated the way you're describing and prognostication was occurring, then the hospital beds that are tied up, the intensive care unit and other hospital beds that are tied up by frail elders, those would be available to take care of the people during the crisis. Is that a fair way to put it?
It's a fair way to put it if we develop interventions that we can use in the home to prevent it from occurring. But even better than that would be earlier up, realizing that these patients need to stay away from anybody who might be infected. And who might be infected? All the people going to the ER. And
Right.
so, yes, so the more you can manage these patients in their home, the better off they'll be. Let me give you a couple of examples. So for COPD, we have emergency kits. All COPD patients on our program in their home have a nebulizer, steroids, and antibiotics waiting in their medicine cabinet for the first signs of an exacerbation. Why? Because the medical evidence is crystal clear. The sooner you start steroids and antibiotics, the quicker they resolve and the less likely they are to be hospitalized. So even waiting a couple of days to go, is this cough getting worse? Don't ask. We'll treat it immediately, and we'll get them under control. And that's how we've decreased for COPD about, I think the hospitalizations dropped by over 60%. So, and that doesn't mean you never get hospitalized. It just means that we're going to try to treat it early to keep it from accelerating.
So help us describe the impact of your program with some of the, I know because I've read your articles and we've had these conversations, but for the audience, kind of give people an idea of just how much impact you're having with the people that you serve.
Well, from the patients and the families, the patient and family satisfaction is extremely high. If you use a Likert scale to evaluate satisfaction with our program, even a 4 or a 5, there's nothing lower than 94%. If you use just a 5, it's still extremely high. But the moral resolution is that these families are resolved about what's going on, because instead of becoming advocates in the ER to do everything for mom, they're advocates in the home to do everything for mom to keep her at home where she had the capacity to tell you what she wanted. 90% of these patients will move to hospice, and 10% either, make other decisions or move out of the area or stuff like that. But the economic impact, separate from the emotional burden and the medical benefits, we save approximately $25,000 to the healthcare system per patient on the program, which I think if you read the Florida tax analysis of our program, it would save the country $103 billion over the next 20 years if we practiced using this type of a model. I actually think that's an underestimate because they included some other community-based programs that do not use no admission as the standard of admission to their program. So it's probably even a little bit higher than that.
Well, that's fantastic. Just fantastic.
Yeah.
Allie, I'm going to turn things over to you.
So I was wondering how the Sharps transition program has been affected by the current pandemic.
Great question. So we're really getting good at telehealth. We do have to do face-to-face visits. It's a hospice mandate, but on intake we do that. We have a lot of screening questions, similar to screening questions for patients that would go to the emergency room. Our staff is all gowned up before they go in, although there's, as you know, there's a crisis and a limited amount of PPE, provider protective equipment. But we are doing a lot of telemedicine visits. There's nothing like holding a person's hand or being in the same room with them. But, under the current crisis, we can still perform our service. We can call them up and ask. It's no different than an office visit for me. I can talk to my patients via telehealth or by phone, but there's nothing the same as being in the room with them. So for now, we're doing a lot of telemedicine visits. Interestingly, we had a recent surge in admissions, not surprisingly, because patients want to stay home instead of having to run off to the emergency room. So I don't want to call that a good thing from a crisis like this, but it was something we've noted.
Well, so you have increased the number of patients that you're serving through the Sharps transition program during this time?
Yes, since the COVID-19 outbreak, yes.
Wow, that's kind of surprising. What
Well,
do you
I think people,
for that?
excuse me?
I was going to say, what do you think accounts for that?
Well, I think people are realizing the value of the program. When you are frail and elderly, you're at risk, and it's not just COVID-19, the coronavirus. You know, the hospital is a dangerous place for the advanced elderly, and we just don't talk about that enough. You know, I mentioned hospital-induced delirium. We cause that in the hospital. It's a quality metric because it is in part preventable by proper management. But the best management is to avoid the hospital completely. It's not the care is bad in the hospital. It's not a lack of professionalism. It's a side effect of hospitalization for the advanced elderly. And the one-year mortality rate for hospital-induced delirium is 30 to 40%. That's worse than COVID-19. It's 80% at 3 years. Yet, we don't recognize silent killers in the advanced elderly because our culture has not studied that well enough, and we're not taught that well enough. And so we don't do in the elderly population, which is something I'm imploring the healthcare industry to do, which is to understand the stages of the geriatric life cycle. When you have your physiologic and cognitive reserve, you're a healthy geriatric patient. And that's where research has been beneficial to you. So once you start to lose your physiologic or your cognitive reserve, the amount of research for you drops dramatically. And when you've manifest signs of being pre-terminal, 6 months to 3 years, the research is even less. But we continue to use the same means to manage these patients, the same standards for which we use 5-star metrics, so diabetes management or cholesterol management or blood pressure management. We use the same culture of hospitalization. All of that is archaic and not adequate. That has to be updated. If you don't know, by 2035, almost 20% of our population will be over the age of 65. And the statistics are that only 6% of randomized control trials specifically look at people aged 65 years of age and older, and 0.1% of randomized control trials look specifically at patients 75 years of age and older. And just to make in the whole thing worse, from our understanding of the geriatric population, healthcare in research has deliberately excluded people over the age of 70 or 75, people with cognitive or functional impairment, people who have been institutionalized, either in assisted living, border cares, or nursing homes, and people with multiple comorbidities. Those are the patients I see in my office every single day. And so when we say we have the medical evidence to manage these, and you go and look up what to do for them, look at the exclusionary criteria. We probably don't have that information. It's because they were part of the exclusionary population. We just extrapolated results from a younger and healthier population and said, hey, well, we're going to apply it to you because we don't have anything better to do. Now that's changing, which is good. But that was not the case 20, 30 years ago when I was working in healthcare and working with the post-acute care. That once we recognize that, we will see how unnecessary much of what we do, well, not only not unnecessary, but inappropriate much of what we do to this demographic has become.
When you graduated from family medicine residency, did you see yourself working with this population? Was that your ultimate goal?
I was very flexible. I only told you many of my hats. I used to work as a utilization manager. I worked in different parts of family medicine. My career took me there, but I always want to do the best no matter where I go. And I just saw the suffering in my geriatric patients, and I couldn't stand it, so I had to do something to fix it. So I didn't see it; it just came to me.
Well, I think it came to you in a big way. I know that when we've invited you to come present at our Innovators Network meeting, or I've seen you present in other venues, your colleagues, not just in family medicine, but in all of medicine, are really impressed So I just want to thank you for what you've done. And let me just ask, where do you see this going? You're not yet 60, you mentioned, so you got a bit of time left. Where would you like to see this go?
Well, the community-based palliative medicine program is just a part of an extension of moving backwards to connect the great care we've done until people are age 75, so long as you're pretty healthy, but moving backwards to integrate care with all of those patients who are starting to develop changes of the elderly and filling in all the blanks that exist in that massive gap in healthcare. And to me, the transitions program or programs such as that will become part of the future of healthcare. Now, I think you know, Larry, already, you may have been a loaded question, but we've won multiple awards for what we're doing,
yes.
So the nation knows what we're doing. We just won the Jefferson Hearst Award. We've won the NACO, National Association of ACOs Innovators Award, 2 Circle of Life Awards. We had the Certificate of Distinction from the Joint Commission. We became California's palliative model for community-based palliative medicine under SB 1004. And that hopefully will become the national model. That's where the Florida tax evaluation came from. So it was based on our model of understanding of how to manage this population. So in the future, either we are going to be forced down that way, which is not my favorite way to do things, or we're going to develop the wisdom that this is just a better way to practice. But I have a personal philosophy, which hopefully inspires other people to want to practice proactive medicine. But my personal philosophy is that it is not our patients' responsibility to get sick so that we can finance ourselves or feel good about our professional skills. As physicians, we should be doing everything we can to keep our patients from needing us. That's good healthcare, not the other way around. Not waiting till they're broken to fix them, keeping them from needing us. And that's where I'd like to see the future go.
I love it. Allie, do you have any other questions?
I don't think so. I think that message really isn't put forth during our medical education, and our education is very much done in a hospital setting. Do you think there's anything we can do better in medical education to kind of promote this proactive care?
Yeah, that's a great question, Ellie. And when I was raised in medical education, I started medical school in 1986, and we were very paternalistic. The healthcare industry seems to be proud of itself because it's gone from being paternalistic to hospital-centric, and that's what you're alluding to. What we really need to do is become patient-centric. And in patient-centric care, we don't focus primarily on the hospital. You do need that education, don't get me wrong. But we need to move all of that professional enthusiasm and aggression in healthcare much further upstream to anticipate what's coming for our patients, to keep them from needing us, and not relying on us to finance, healthcare, them to finance healthcare. We should just be keeping our population as healthy as possible. And that's a concept that, that's a culture change. Culture change is much harder to do than, like I said, introducing a new medication or a new procedure. And I think once more people realize that that's a possibility, and once there's more seniors that start to demand it, that change will occur.
Well, and let's hope that this
100% agree.
podcast and interview can help that along the way as others across the country come to understand what's possible. So, Dr.
Yep.
Hofer, I want to thank you very much for spending time with us today, and I look forward to continuing our collaboration.
Happy to do so, Larry. Ellie, it's nice to meet you. And
Nice
anytime
to meet
you
you
need me,
too.
please let me know. All right, take care.
Take care. Bye-bye.